We're now live, Chair.
Okay, thank you very much. So good morning, everybody, and welcome to this meeting of the Health and Wellbeing Board. This is the first meeting since the Council's annual meeting. So we do have, first of all, welcome Councillor Monteith to her first meeting, who's taken over as the Conservative member on this on the Health and Wellbeing Board. Welcome, Brenda. Can I also, I'm sure I'm going to get some of these wrong. So can I also give a big welcome to Alison Lowe, Deputy Mayor for Policing, and Alison's presentation, which we'll bring fairly early, is one of the main items for today's agenda. Also, Emmeline Irving. Emmeline's been with us in the past, I think, to talk about trauma-based care, but I know you've been asked to come specifically for this item and the connections. And can I also welcome, I think, Julie Robinson from Voluntary Action Calderdale. I think this is your first meeting as well, so welcome, Julie. And apologies if I've missed anybody else I should welcome. I suppose, Mark, this is your first meeting clerking this, isn't it? So I'll move us on to the agenda. What I propose to do is to take items 1 to 3 and then bring forward item 5s, because I know Alison has plenty of time but does need to get away. Then after minutes 4, we didn't include question time on the minutes. We do have a question from Councillor Hutchinson, and again I intend to take that after we've taken the minutes of the last meeting, after item 4, if that's okay. So item 1 is substituted, nominated, and any apologies. Mark, can I check first of all with you that any that you're aware of?
Yes, Chair. We have apologies from Councillor Adam Wilkinson, Karen Huntley, Sue Lewis, Sarah Baker. We also have apologies from Karen Jackson, with Tim Fox substituting today, and apologies from Daryl Thompson, and Chris Lennox is substituting.
Thank you. I think we also have, sorry if you said this, do we also have apologies from Robin Tuddenham, I think? I know he's not able to join us, so we had that. And apologies from Councillor Megan Swift as well. Item 2, members' interests. To remind members to declare any specific interests. Of course, we all have registers of interest with our own specific organisations, which are taken as read. But if there are particular interests in any item, then I'd encourage people, then I'd ask people to declare them, particularly if they might be pecuniary or could be perceived to be substantive. And third item, admission of the public. There are no confidential items on this agenda. So I'll take us straight on then to item 5. And again, welcome Alison Lowe, Deputy Mayor of West Yorkshire. I think, Alison, you're going to give us a short presentation on the police and crime plan. And this is an opportunity for us to comment on it, but also particularly to think about the connections between the West Yorkshire Police and Crime Plan and our own wellbeing strategy. So, Alison, I'll hand over to you.
Brilliant. So, yeah, thank you so much for coming. I'm very excited to be here today. It's a very short presentation you'll be happy to hear. I'm just going to tell you about the way that the Police and Crime Plan has been developed and how we hope that we can use that to continue the partnership arrangements that have already started. So the new plan, which hopefully you've all seen, has got 4 priorities and 3 cross-cutting themes. Our vision, which was co-produced with our PEG, our executive group, our partnership exec group, is about having a safe and just and inclusive West Yorkshire. And we're hoping to achieve that via our 4 priorities: supporting victims and witnesses and improving criminal justice outcomes, because justice for people is key, keeping people safe and building resilience. When we did the Tell Tracy consultation process, actually this is the theme that came highest from the 4,000 people plus we spoke to through that process. CSEA actually was #1 for the first time ever. That was what people were interested in. So keeping people safe and building resilience was a key objective of the communities of West Yorkshire. Safer places and thriving communities is another one of the priorities, and then responding to multiple and complex needs. So there are a few areas there that I can clearly see the coterminosity between the work that you're all doing in your communities and across the health spectrum, and the work that we're doing to keep people safe. And then we had 3 cross-cutting themes where we're going to put a lot of our energies, and which we hope will be underpinning principles of all our activity. And they are the safety of women and girls, one of the Mayor's pledges when she was elected back in May 2021. Equality, diversity and inclusion. West Yorkshire is an incredibly diverse county, which is one of the assets that we all enjoy, and we wanted to exploit that through the plan, but as well as celebrate it. And then early intervention and prevention, again, another area of coterminosity between the work that we're doing and the work that you're doing. So what have we done so far? We've got the plan, but as part of the Mayor's pledges, we've also added 252 additional police officers. By April this year, we've had another 252, and obviously the Mayor's pledge was that you'd get 750. We would get 750 by the end of her 3-year term, and we're on track to do that. We've invested over £2 million in IDVA and ISVA posts to support domestic and sexual violence victims. We've brought in £3.3 million of Ministry of Justice funding, and that's to support vital victim services, including the Sexual Assault Referral Centre, which is a great partnership with health. We're working to eliminate serious casualties on our roads through our Pan West Yorkshire Vision Zero board, which I am chairing, bringing together all the local authorities and getting that coherence to prevent and eliminate deaths on our roads. We're building safer places together through safer streets and safer safety of women at night funds, and we've brought in over £800,000 in the last 12 months under those 2 funding streams. And we've been setting out the priorities and principles of our new strategy for women and girls through a series of co-designed events, which hopefully some of you have been invited to, because we want to get it right for women and girls in West Yorkshire. And there's lots of ways that we've identified that we've got commonalities and ways that we can definitely work together. Issues for policing and for our communities are also areas where we can work together. And obviously mental health is one of the key areas where we're already investing in support in our contact centres, for example, drug and alcohol misuse. There's a lot of money coming into West Yorkshire, and the Mayor's office also contributes considerable amounts of money to, for example, drug testing, which is all part of supporting people through that health pathway. We share interests around rape and sexual offences, domestic abuse, addressing childhood trauma. All these are shared interests and shared areas and opportunities for partnership working, especially under the responding to multiple and complex needs area of the plan. And it's quite innovative that we've got responding to multiple and complex needs. The public didn't really understand this element of the plan, but the Mayor was really, really clear that if we didn't acknowledge the complexities of our communities and the fact that some people who are involved in offending are also victims, then we wouldn't really achieve our objectives of early intervention and prevention. So some great examples already of how we're working together. So we've got the Violence Reduction Unit, which was established in 2019, and they take a whole system public health approach to serious violence in West Yorkshire. And in fact, works alongside the Violence Reduction Unit and the West Yorkshire Adversity, Trauma and Resilience Programme is part of the work of the VRU, and we're very lucky to have her is helping us to roll that training, that programme out across policing and across all partners across West Yorkshire. We work in partnership with health, local authority, education, the wider criminal justice system, and the VIU had a 1.8 million intervention portfolio in 21-22. The great news is we've just been given a 3-year deal here in West Yorkshire, and that is £14 million for West Yorkshire. And that public health approach is a golden thread throughout the whole of that investment. And so there's going to be lots more local interventions across Calderdale, across Kirklees and the rest that will support your work and also help to deliver the objectives of the plan. We'll talk about that more at a future meeting as the detail of that that money's worked through. So I've got lots of examples of a collaboration already with our health and social care partners. One such example is the hospital A&E project where we are supporting people to move away from violent lifestyle. So there are people actually embedded in A&E. So for example, if a young person comes with a knife injury, we're able to intervene and give that support. And also those frequent attenders, A&E departments, staff can intervene there as well. We've obviously got a brilliant partnership already with the SARC, which is a state-of-the-art facility supporting people who have experienced rape and serious sexual assault. And then we've also got mental health cars with mental health practitioners accompanying West Yorkshire police officers to support their response work. But there's more that we can do. We want to strengthen our partnerships. We want to build on the work that we've done, and we want to develop new partnerships with new stakeholders. And having a mayor is a really great opportunity to do more. And she has got powers that she can bring to the table to help that work do even more good in our region. We want to continue to build on that public health approach, and we want to roll out that trauma-informed practice and response across the whole of the West Yorkshire Combined Authority and beyond, if that's possible. And we want to think differently to identify opportunities for early intervention and co-production and tackle the root causes of the issues that we're seeing in the A&E departments and custody suites, for example. So finally, I'll just talk to you about performance, because obviously you're only as good as your last league table. And here in West Yorkshire, we've obviously are an outstanding force. I'm not the police, by the way. I'm just I'm in policing so much. I think I'm part of them, but I'm not. And we hold the police to account for their performance and delivery of the plan using performance measures that we have developed. Some of those are national performance measures, some of those are locally agreed performance measures that we've developed, and they are in response to the priorities that have been set by the public that we consulted. And we've got the performance framework on our website if you want to have a look at that. But here it is. It's very small. I can see it a bit bigger on this screen, but as I say, it's in the plan. It's on the website. But under the 4 priority areas, we've tried to come up with some indicators, metrics, and also looked at baseline data to be able to measure the progress that the police and partners could have tried to widen this beyond just police to our other local criminal justice board partners and also CSP partners. So, for example, in supporting victims and witnesses and improving criminal justice outcomes, we're looking at LCJB criminal justice measures, for example. We're looking at response to 999 calls. That this is data now that we can get through the Beating Crime Plan from government. So we're using this to drive our understanding of how well police and partners are delivering for our communities. Keeping people safe and building resilience. We're looking at national crime and policing measures around drug supply, county lines, indicators, for example, but we're also looking to increase the numbers of DVPOs, DVPNs, increase the number of stalking prevention orders, for example. So for the first time, we've got this performance framework. We're working through it, and we hope that at the end of the 3-year period, we're able to demonstrate to the people of West Yorkshire that we've delivered, but also that they are feeling that West Yorkshire is more just, is more fair, and is definitely more inclusive. Thank you very much.
Thanks very much, Alison. I'll invite some questions and comments. Perhaps I could just start by checking, if I may. I think you said at the start this is the draft plan at the moment. What's the sort of timescale for any sort of consultation and adoption?
No, so it's the final plan. This is it. It was launched in March, yeah. So it's not draft. It's final, and but it's a living, breathing document, and clearly there'll be annual reviews just to check in that we're on the right path. But there are a series of action plans of other plans that we're going to develop in partnership with this plan. So some sister documents. So we're developing first and foremost the violence against women and girls strategy, and that should be developed by September. So we've been out and about asking people their priorities for the women and girls, violence against women and girls plan. But there's one on criminal justice, for example. There's a whole range of other strategies that we're going to develop to sit underneath this plan, because we want to get that detailed, granular work pinned down, and the evidence to be demonstrated to the citizens of West Yorkshire.
Thanks, Alison. Thanks for that clarification. So, I mean, clearly this item is an opportunity not just to talk about the plan itself, but about those connections with our own wellbeing strategy and priorities and issues. So can I open this up for sort of questions and comments? People either use the raise hand functions, or I'll try to see physical hands on screens, but that's not always as easy. So I've got Debs and then Julie, and I think Alison, I'll take 2 or 3 comments. Well, I've got quite a few now, so I'll take probably a cluster of 2 or 3 comments and then bring you back in if that's okay. So I'll take the first 3. So Debs and then Julie.
Oh, thanks so much, Alison, for sharing the plan. It's great, and I'm particularly really happy to see the focus on safe areas, safe communities, and neighbourhoods and places. Because, as you know, it's such a critical determinant of health, isn't it? Feeling safe, and as you're probably aware, our wellbeing strategy focuses on. We've got some really clear priority outcomes that we want to achieve, and I really believe feeling safe is a sort of a key influence over all of them. So children being ready for school, young people having hope and aspiration, good emotional health and well-being, and fewer suicides, and older people living in vibrant communities and having really good social networks. There are sort of our 4 priority outcomes. We've also got our active Calderdale programme as well, which is about people being more active, and we know, I think, that feeling safe will really help with all of those. So I was just really interested in your thoughts and reflections on what more we can do together, I guess, so that this plan can contribute to our outcomes, but equally we in Calderdale can support the achievement of that plan.
Are you taking a few together, or am I answering each in turn?
Are you okay if I take a few together?
Yeah.
Is that all right? So I'll take Julie and Emmeline, and then come back to you, Alison, if that's okay.
Morning, Alison. It's Julie Jenkins, Director of Children and People Services. Really good to see the plan. Thanks for your presentation. I just wanted to give you some feedback around some of the work that's been going on with West Yorkshire Police in Calderdale, and some of the things that you're leading on. You know, we know that to have a trauma-informed workforce right across the piece is going to really help our children and young people build that resilience. And you've been doing a lot of work as well around exclusions from school, and that's a really high priority for us as well in Calderdale. But I just wanted to say a huge thank you, to you, but also to West Yorkshire Police for the investment that you've put into early help. The early help action team, the joint work with the youth offending team, we're really seeing a change and reduction in the number of children in need in the borough and children on child protection plans. And I think that's because we're getting in there at a much earlier level. And I just wanted to put on your radar, in respect of more integrated working to come, Josh McAllister's National Review of Children's Social Care that got published a couple of weeks ago. And there's been a national panel investigation into the recent serious child deaths, including Star Hobson in Bradford. And what that's saying is, although we've got integrated police officers, etc., in the very front line, in the MAST team, that it'll become much more integrated in the longer term work in the child protection looked after teams, etc. So I just wanted to see whether, you know, you and your office were kind of aware of that direction of travel. There's recommendations made to government, but we'll no doubt hear more about their response. But it's looking like better communication, more integrated staff on the ground. Thanks, Alison.
Thank you.
Thanks. And Em?
Yeah, thanks, Councillor Swift. I just wanted to bring in some of the links and some of the close work in the Improving Population Health, the VRU, are doing that absolutely aligns with what Alison has just described, and to thank Alison as well, because she's just said she'll be the chair of the Adversity Trauma and Resilience Strategy Board going forward for West Yorkshire, which is fantastic. But in line with lots of the things that Alison mentioned, in Calderdale, actually, as we speak, Warren Larkin is training your police officers today in Halifax in person around trauma informed. Your response teams are going to be trained in August, and your wider district teams are being trained over the next 5 weeks. And that will continue to roll out. Locala have just come forward wanting to be a trauma informed organisation, which is absolutely amazing. We're supporting them. And the extension of the A&E work that Alison mentioned has been extended to Calderdale and Huddersfield Foundation Trust. So we received some funding from NHS England as well as the Violence Reduction Unit to broaden the remit as well. So they're not just looking at serious violence, they're looking at trauma and adversity. They're looking at adults with complexity. So it aligns very much to Burnt Bridges and the work that you've been doing in Calderdale. The majority of your Calderdale GPs have been able to access training. Some of there's still some more to deliver, and the REACH training for trauma informed has also been piloted in Calderdale. So there's been lots of really exciting work happening around the trauma informed journey in Calderdale. The other work that's happening at system level is we've just launched some work around the justice system and trauma informed. We're doing a birth to prison pathway. We're currently working with Armley Prison, Wetherby YOI and Wealdstone to become trauma-informed organisations and to look at how we can support young people from birth with those things that Debs was talking about and that Julie was talking around, how we can really get the root causes right and take them off that pathway from birth to prison. So there's a big piece of work happening about that, and we're presenting it at the Four Nations Conference actually. So there is a Four Nations Policing Conference happening that's dedicated to trauma informed next week. In relation to some of the work around communities feeling safe, I think our inequalities programme is doing a lot around that as well. The Core 20+5 funding that you're just about to receive in Calderdale and across the other places will absolutely look at some of those root causes and the inequalities that underpin some of the reasons why people end up going down these routes of violence and criminal justice, etc. And then in line with the plan around the equity and inclusion work, we're about to deliver some work across West Yorkshire and develop an inclusion health unit, as well as we've got the health equity fellows that are working across the system, all of which are there as a resource to place if they want to be involved. And finally, Debs was really kind enough to run a workshop with us in Calderdale a month or two ago to look at our prevention refresh for the ICS as well, which includes the work of the Violence Reduction Unit and the ATR programme. And we're just about to launch the priorities of that, but some of the priorities you'll be glad to know, Debs, that have come out on top are very much around community safety, poverty and adversity trauma and resilience. So there's some of the things that will be taken forward at a system level. So I thought it might be useful to for you to have those links.
Thank you. Alison, do you want to come back on anything from those three before I go to Ashley and Jenny?
Yes, thank you. So yeah, just on that final point, those final points from Em, the work that we're doing on becoming trauma informed is really, really important, and I'm so delighted that West Yorkshire Police have bought into the need to have that trauma informed lens on all the work that they're doing. And just to say, I have visited Calderdale, I've visited Sally, one of your landlords, on Union Street, visited some of the people who live there. Amazing work that Neve Cullen is doing to support Sally and to make sure that those people who are the most disadvantaged and absolutely encapsulate that that complex need, responding to multiple and complex needs, which is in our plan. I'm really, really committed to working with you to supporting that group and to supporting Sally to do the brilliant work that she's doing alongside police, because she's an asset here. I have to say she's an asset, and I think she's great. On your point, Debs, on what can we do for each other, well, clearly keeping talking to each other, understanding the coterminosities of the roles, the money, because the drugs money that's coming in is a huge opportunity for us to work more closely together, for example. Obviously Wakefield is an ADA site, but there will be more opportunities across West Yorkshire as the funding rolls out. You might be in year 3? Yeah, year 3, which is unfortunate, but yeah, there are some opportunities. But the learning that comes from the rest of West Yorkshire can definitely be an opportunity also, so that when you do get your funding, the additional funding, you can run with it from day one. And obviously the opportunities of the VRU funding are innumerable. So the Safety of Women at Night funding meant that West Yorkshire Police could be a hub in the centre of Calderdale for several months, be there for people in need, all people, but particularly women who were at risk. We were able to provide that resource. That's something we'd love to do more of. So there's lots and lots of things that we can do more of together. Yeah, I really look forward to understanding better what your priorities are, so that we can do more of that. Having said that, I think our plan is very similar to most of your community safety partnership strategies, which we've also seen and aligned to our plan, because we didn't want to start from a blank piece of page. And of course, all our partners were invited to feed back into the plan, and all CSPs did, including Calderdale, so that was great. Julie, yeah, thank you for your thanks around the support from police and the early help action team support. I think that's funded by the VRU, and I think it's I think I've just agreed that that's going to be funded again over the summer. I think that's what. Yeah, don't quote me, but I think
okay, that'd be
yeah,
good.
Yeah, I think that we've just agreed that. I'll have to go back to my papers and check it was Calderdale, but I think it was. And obviously the police. So one of the things that Tracy and I have done is, when we got the learning report for Star Hobson and Arthur Lavinia Hughes, is that we asked the police what their response was, and we've been reassured that they're really clear about the responsibilities that fall to them as a result of that report, not just in Bradford, but wider. In fact, I spoke to them at the community outcomes meeting this week about some of the detail of the work that they're doing. So they're all over it. They've grown their safeguarding team by a further 79 staff. And they're really wanting to embed the recommendations, not just the local ones, but also the national ones, and they're working through that with their safeguarding team. You know, it's a work in progress. There's lots of learning in there for all of us, but that partnership is just critical, because we keep on having these terrible cases, and it appears that the lessons are not being learned, and you know, and it shames us all. And I don't want my legacy to be that I presided over a force that again failed to listen and failed to learn. So that's definitely something that Tracy and I are very, very alive to, and holding the police to account for the work that they're doing.
Thank you, Alison.
Thank you.
Thanks, Alison. Go to Councillor Ashley Evans, and then Councillor Jenny Lynn. And I should just say, welcome Jenny, and say Jenny is the co-chair of the Community Safety Partnership, so that's why we asked her to come along for this item. Ashley.
Thank you, Chair, and thank you, Alison, for the report. There's some really good stuff in there, particularly the women and girls side of things, which is what we all know is a major issue: mental health and the importance of early help and all those things. At a much more mundane level, and speaking really as a ward councillor, one of the frequent most common, I think any other councillor would come up with this, is speeding, dangerous driving, and antisocial driving in wards, in areas right across West Yorkshire. I think I know it's a difficult problem, but it really is a major issue which affects people who live here. It has an impact on the community, how they feel safe and feeling safe. I know there are things like Operation Hormill, which is a tremendous development in the right direction. But I really do think we need to be seen to be doing more in relation to not just speeding and the dangerous driving, but the antisocial nature of these things, because it has such an impact on communities. It's a difficult one to do a lot about, and I know it's about numbers of police available and all those sorts of things, but we really do need to put some effort in trying to deal with this problem, which is a major issue for members of the community and is regularly repeated to us when we knock on doors and open emails and so on. So I think it is a critical area. There are lots of other things you're working on there which are hugely important. I'm not denigrating those at all. I agree with the vast majority of them. But I really do think this is something where we need to be creative, more effective, more seen to be doing more. Sorry, it's one of my little hobby horses. So I've got carried away there. I'll leave you to it and on to Jenny or whatever.
Thanks, Ashley. I'm sure Alison wants a bit more possibly about Vision Zero when she comes back. Jenny?
Yes, thank you very much. And thank you, Chair, for the invitation to come along. Yeah, and it's great to be here with Alison, who was always such a kind of great advocate for joint working, preventive action, and so on and so forth. I mean, I haven't got a great deal to add other than to say that that the Community Safety Partnership was delighted to be able to be supportive of the plan. I think if there's one thing that I would add on a kind of a personal note is that, particularly in relation to the safer places and thriving communities, I believe that the Health and Wellbeing Board and many of the partners around this, around this in this meeting, can play a part in terms of what we're doing to kind of support our young people with activities and great things to do. Poor old Alison, I bored her to death with mention about how we know we could do some preventive work with the police up at Mixenden Activity Centre in North Halifax, and I still want to get that sorted, and I'm still trying to hack away through the undergrowth with it. But it seems to me that we know that we have had to lose a lot of our open access youth service support in Calderdale over the last few years because of cutbacks and so on. But I just feel it's incumbent on all of us to do what we can to try to support positive activities for young people, whether it's sports, whether it's leisure, etc., etc. I'm not necessarily saying I want everybody to play table tennis, but I do want us to figure out a way in which we can, down the line, prevent so many calls on the police's time and so much antisocial behaviour of the type that Councillor Ashley Evans has just been talking about. And I think some of that starts early on with making sure that young people are not bored to death. Anyway, that's it from me. Thank you.
Yeah.
Thanks, Jenny. Alison?
Yeah, thank you. So, Councillor Evans, I absolutely agree that antisocial use of cars, speeding is a critical part of communities feeling safe, and actually it came third in the consultation that we did, the Tell Tracy consultation. CSEA came first, but speeding came third. So it's very much a priority for our communities. I'm delighted that Halifax, Calderdale have continued to invest in Hormill, obviously using some of the monies that our office contributes to the CSP. But it's an investment that you make that other local authorities other than Bradford don't make, and you see the benefit, and that they're not as well placed as you are as a result of Hormill. But we also recognise that there's more that we could be doing as a partnership together. So speeding is not just about police, because obviously you can't have a police officer in a police car at every street corner waiting to pick up these idiots who are choosing to behave antisocially. It is about bringing all the community together, bringing all the agencies together, and that's why we set up Vision Zero and the Vision Zero board. So Vision Zero is not our thing. It was created somewhere else, America, I think, some years ago. But what it does is it creates that strategic oversight of all the activity across a county like West Yorkshire, and it holds each of those local authorities to account for setting a Vision Zero plan or a strategy, which is Calderdale is very well advanced. Leeds is in the consultation with the public phase, and I think Calderdale is not far off that stage. other bits of West Yorkshire are not as advanced as Calderdale, I have to say. And once you've got your Vision Zero strategy, which is being consulted, and it's about eliminating road deaths, it's about eliminating harm through antisocial use of cars and other transport, other vehicles, and it's about looking at the design of roads. So that's not just about the police, that's about local authority, highways departments. It's also about Highways England, because obviously you have got bits of your roadway that belongs to Highways England. It's about communicating the positive campaign messages, but also explaining to people why it's really important that Vision Zero is something that's embraced by our communities, because this is individuals in communities doing this to their communities. So we have to get buy-in, a bit like drink drive campaigns, which are obviously so well embedded nowadays. So it's a multi-pronged strategy that cuts across a wide variety of activity. And once all those plans have been put in place, the West Yorkshire Combined Authority will also have its own overarching plan, because they've got a role to play as well, because they've got such a big role to play in transport. That's what we'll then be holding all the directors of highways and the officers to account for politically, because there hasn't been that political accountability. We're also working with the West Yorkshire Camera Safety Partnership. It's changed its name yet again. We had a Vision Zero board this week, which Councillor Tim Swift was in attendance at, and we got we had a report back on the safety partnership and how that works, because we'd like to have a bit more political oversight of that, because obviously we need to understand better how decisions are made around cameras. What has been an issue is that the Department for Transport guidance of 1974, yes, I'll say it again, 1974, has not been updated. I have asked my local MP to chase that in Parliament, Kim Leadbeater, and she has. And the government have said that that's probably going to be completed by December 2022. But as we were originally told January 2022, I'll be holding my breath. So what the Vision Zero board have agreed this week is that they're actually going to bring their own guidance. They're going to refresh their own guidance, so that local people and local councillors in particular can have more say and have more influence over the placing situation of speed cameras in our localities, because we know that I was a councillor for 29 years, so I have been there and got that t-shirt. We know that we get a lot of intelligence from our communities, and we know where accidents are likely to happen. Currently, an accident has had to happen and someone's had to die before you get a camera, but we want to prevent that in the first instance, because I believe that the public have not been very well served by the current DFT guidance. So we're coming at it from all sorts of different angles. And then finally, the Mayor has put in a bid to the Home Office for some additional funding under Safer Streets for some off-road and quad bike activity across the whole of West Yorkshire, over £500,000. So we put that bid in a couple of weeks ago. We might get it. Hopefully we'll get it. And then that will be more activity in Calderdale and elsewhere to deal with off-road bikes, the quad bikes that it's low-level nuisance, but actually very high-level risk. So we're on it. It's a massive task, but it's not just a role for police, it's a role for all of us, and we all need to be on the same page. Yeah, Jenny, I'm with you. And actually, after this meeting, what I shall do is I'll email the director of the VRU, Jackie, about potentially looking at something in Mixenden and North Halifax, because I don't know if it's on her. Yeah, I don't know if it's something she's alive to. So I'll get her team to come back to Calderdale CSP and talk about what opportunities they can do there.
Thanks, that's great, Alison. Anna, were you trying to indicate? No, oh. You're on mute, I'm afraid, so I didn't hear. Yeah.
Sorry, no, I was going to comment on the adversity trauma coordinators in A&E and that work, but Emmeline's referenced that. That's what I was going to reference.
Oh, thank you, because I was going to ask whether there was scope for that work being rolled out to Calderdale and Huddersfield. So yeah, that's good. Thank you. Okay, I'll go to Stephen. Dr. Cleesby next, and then let Ashley come back briefly. Stephen.
Thank you very much, Chair. Yeah, and Alison's enthusiasm is contagious. Wonderful presentation, so much happening. But I think if we use the analogy of someone with heart disease getting a quadruple bypass, and that's what we should be focusing on, that I think in terms of the approach that I've heard generally, despite all the wonderful things and all the enthusiasm, so happy that Jenny mentioned prevention and young people and younger youth. One of our aspirations as a health and wellbeing board, and one of our hopes for the young people in Calderdale, is that before they leave school, they'll have hope and they will have aspirations for the future and a plan as to what they would like to achieve in life. And I think if we could focus on this, it would be a way of getting into the causes of crime, because we haven't really mentioned them really, despite all this. I mean, we've sort of fringed around the edges a little bit, but health inequalities, economic, social inequalities, social injustice, prejudice and ignorance, lack of education, the causes of crime. Surely we need to be focusing on that and thinking about, the sort of 12 to 15-year-olds and what's the future going to bring for them, and investing disproportionately in challenged areas and really lifting up the hopes and the lives of our young people in Calderdale.
Thanks, Stephen. Ashley, do you want to come back, and then Emily?
Thank you. Thank you, Chair. Just a very quick one. Very pleased with the positive response from Alison in relation to my rant on speeding. Also pleased to hear looking at funding for dealing with the off-road and quad bikes, which I didn't mention, which is clearly a major problem. Can I just be very parochial once again? You did make reference to looking at funding, getting funding for Mixenden and North Halifax. Can I just say my ward, Worley, is part of North Halifax, and very often it's forgotten about as being part of North Halifax. It tends to be Mixenden and so on, and not us. We do have a problem with that, a major problem, because we have open spaces like Rosehead Moor, which has quad bike and off-road bike problems. Please, can you make sure we get included in that? End of request. Thank you.
Thank you. Before we get more ward requests, okay, but nicely done. Emily?
Yeah, I just wanted to come in on the prevention and the young people element. So obviously the Violence Reduction Unit, as Alison said, is investing lots of funding into how we can encourage young people to get involved in other activities, but there's also lots of work happening within the ICS as well. So I don't know if you know, we've got a non-exec member for Future Generations, Professor Becky Mulby, and we are going to be looking at, through economic recovery and through the inequalities agenda, how we work with our Future Generations non-exec member to look at what we do for our young people. I was having a conversation with Cathy Elliott, our chair designate, the other day around the fact that if we don't start to look at young people understanding that they can realise their aspirations, I think what we often do is dismiss that young people have aspirations. They do. They just need the self-belief that they can realise them. And that's something that's really critical to the Improving Population Health Programme and the Future Generations work, and also the Children, Young People's Families Programme within the ICS. So there's lots of work happening across the system and conversations that we'd be more than happy to share in more detail with people if they're interested. And obviously the adversity, trauma and resilience work is absolutely about prevention. And it is about how we get those young people off those paths and those journeys from birth, from preconception even, where they may be predetermined to go down a life of crime or antisocial behaviour, etc. And we know that the majority of young people that are struggling in school, are struggling or excluded, etc., there's trauma going on in their life. So one of the biggest things we can do for our young people is really understand the impact of trauma and adversity and how that has, and obviously tackling poverty. Poverty is just going to explode. I know I'm preaching to the converted here, but again, that's something that's going to prevent young people from being able to realise their aspirations. So there's lots of things going on across the system. We'd be more than happy to catch up with anybody offline about them.
Thanks very much, Emily. Alison, I'm aware you need to get away shortly, so is there anything you want to sum up on?
Yeah, just a couple of things. Obviously, in relation to Whalley, just to say that I know Whalley very well. I used to live in Halifax. I used to work in Halifax. but it's up to the CSP. So all the monies that come in via the Mayor's office are decided upon by your community safety partnership, and we wouldn't want to interfere because they've got the local knowledge. So that's where you need to put the influence, and we'll be very happy to see money going to Orley, subject to agreement by your CSP. On the question of health inequalities, just to say, Dr. Cleesby, that I sat on the ICS review of health inequalities. I sat on the board that was led by Professor Donna Kinnair, Professor Dame Donna Kinnair, and I chaired the voluntary sector accountability scrutiny panel that sat alongside it. So I am really passionate about achieving those objectives, and I worked in third sector charity Touchstone for nearly 18 years as a chief exec. The areas of most interest were BME communities, refugees, asylum seekers, etc. So I've got some really keen interest in understanding, but also the ICS, as a result of all the health inequalities work that they did, have approached the Mayor, who does not have responsibility for health, unlike her counterpart in Greater Manchester, but still she's very interested in understanding the opportunities of her role and eliminating health inequalities. So the ICS are funding some activity in the Mayor's office for 3 years to help to deliver that health inequalities report, the recommendations contained within that report. And there's going to be an inclusion champion and a small team based in the Mayor's office, part funded by the ICS, to deliver some of that. So once that's up and running, it's taken a long time for various reasons, but once that's up and running, we're really happy to do a paper and send it to this body at some point in the future. And also just to say that in terms of young people, West Yorkshire Police is the only force in the country that has commissioned a programme, an education programme called Police Education, which is for years 1 to 13, and it's all about preventing young people being criminalised, being exploited. So it ranges from online abuse, hate crime, exploitation by criminal gangs. It covers a whole range of potential risks that young people face and are faced with, and hopefully by giving people that resilience, that capacity and capability to handle some of the wickedness that exists in our community, they will have more hope, they will have more joy, and that's part of the hope for all that we all have for our young people, I know, around this table.
Thanks so much, Alison, and thank you for your time. That was a really, really lively and stimulating discussion, and so thank you for everybody who contributed to that. And we'll no doubt pick on some of the more specific programmes and want to make sure that we feed into those, not necessarily through this board, through our other partnership structures in the same way. So thank you very much for that item. We'll move on now, and thank you. So item 4 is the minutes of the meeting held on the 3rd of March. I don't think I was actually there, but could I just check, are we happy to agree those as a correct record? Are there any? Thank you. No points or issues arising from them, I don't think. Okay, thank you. I should have just mentioned when we were doing the welcomes and introductions earlier, I should perhaps also have mentioned on a different, slightly sad note, that this will be the last formal meeting of Health and Wellbeing Board that Ian Baines attends. Thank you. Shall we want to record our thanks to Ian for his work in Calderdale and his contribution to shared working. You'll be very, very sadly missed, Ian, and hopefully I don't think we can quite confirm news about your successor yesterday, but there was interviews held, and we'll be able to send out details very, very shortly, but you will be a hard act to follow. Thank you.
Thank you.
So I said at this point I would include questions from councillors and the public, and we have a question from Councillor Hutchinson. So Colin, the full question has been circulated, but I'll hand over to you to set out what it is.
Thank you very much, Chair, for this opportunity. I would like to put my question in context with item 6, as none of you members of this board will need reminding. There's a major restructuring of the NHS and care services going on at the end of this month. New structures, but familiar faces operating in the place formerly known as Calderdale, with which they're familiar, problems with which they're familiar. The restructuring offers risks, but also opportunities. Subsidiarity plays a large part in the theory of the restructuring, with decisions being taken as close as possible to the people that the new structures will be serving. Calderdale, though, has the smallest population out of 5 places that make up West Yorkshire. So if subsidiarity is going to be real, we need to have a very well-crafted strategy and delivery plan, which is covered by the terms of reference in the Health and Wellbeing Board that you'll be debating in item 6, particularly terms 2 and functions 2 and 6. We really need to take the opportunity to advocate as strongly as possible for the needs of the people of Calderdale through a very well-structured plan. At Skirkett Ward Forum last night, this is where members of the public come and tell councillors what's wrong with their lives and ask for their help. The agenda is set very much by the people who attend. Over half the time was taken up with problems of access to healthcare in Skirkett. Not so much the interaction between patient and clinician, but the ability of the NHS to bring patient and clinician together in the same real or virtual space at the same time. The Trust's appointment service for very many years has been sending patients appointments in Huddersfield when the clinics are actually taking place in Halifax, or vice versa. And the Trust has also withdrawn the ability for patients to use the shuttle bus between hospital sites. And there is no prospect at the moment of seeing that being restored. But primary care is my principal concern at the moment, and access to primary care. My family are registered with the practice in Skirkett at Rosegarth and Siddle. Back in 2015, Secretary of State made pledges that he would increase the number of full-time equivalent general practitioners by 5,000 within 5 years. That pledge was boosted in 2019, but the number of GPs, over full-time equivalent GPs, has actually fallen by over nearly 1,500. Although record numbers of young doctors are being trained as GPs, this doesn't compensate for the number of GPs who are leaving the profession. At the same time, the average number of patients registered with each GP has increased by 300 or 16%. And as we know from the structure of the population, many more of them are elderly, many more of them have multiple conditions. Using NHS workforce data, if we look across the 5 places of West Yorkshire, Calderdale is least well provided with GPs. We have over 2,000 patients per general practitioner. Bradford has 1,600. And the other boroughs, it's in between. So despite the best efforts of general practitioners and the staff that they employ and the staff that the PCNs employ, the fact that the number of consultations are at all-time high, it's no surprise that patients are having difficulty at accessing the problem. But this varies very much between practices. And problems have been particularly severe at Rosegarth practice for, I would say, 2 years at least. Many patients, if they phone up, are having to hang on the phone for 2 hours or more to get through to a receptionist, or are simply met by an engaged tone, which leaves them with a sense of abandonment. As a patient, I can go onto the system online, booking system, to try and make an appointment online. but I'm met with a message that says there are no available sessions for appointments for the next 2 weeks. Go to NHS 111 and they usually tell people to contact their own practice. So you get stuck in a repeating loop. So we shouldn't be surprised if people end up going off to accident and emergency. People understand that the system is under pressure, but the frustration of not being able to get to step number one of speaking to a real live person to explain what it is you want is immensely frustrating, and having an appropriate number of manned telephone lines at the practice would seem to be a very basic first step to somebody as simple as myself. We've sought an understanding of the actions that are being taken and the problems that are occurring at Rosegarth through the CCG and through the primary care network, but we've simply received bland assurances that steps are being taken with no idea of why there are problems or what those steps are, and nothing that we can take back to our constituents. We understand that there's a national policy to train and recruit physician associates, usually people with a science-based degree who receive another couple of years of training of clinical medicine to work within primary care teams and support general practitioners and increase the capacity to see patients. The Royal College of Physicians have emphasised the need for close clinical and pastoral supervision of physician associates by experienced GPs within those teams, particularly in the first year that they're embedded within that team. But if there's very few GPs available to do that supervision, then corners are cut. And on Monday, BBC's Panorama programme went undercover in a practice owned by the subsidiary of a large American corporation called Operos, which is now the largest provider of primary care services in England. And it showed that Operos employ half the number of GPs per head of the population that is normal within the NHS. And it showed graphically the risks of employing physician associates without sufficient close supervision by experienced, fully trained GPs. It also showed the risk of documents coming back from laboratories, diagnostic services and outpatient services and discharged patients from secondary care coming to those practices and not being reviewed by an experienced eye for up to 6 months, if ever. So my questions are basically, is the board able to, so the reason that Operos has been able to take over these practices is because of something called the Alternative Provider of Medical Services Contract Pathway, which was set up in about 2006, where non-medically, people other than GPs can take over providing primary care services. So what I want to know is, I seek an assurance that the ongoing problems at Rosegarth practice will not be addressed through an APMS, an Alternative Provider of Medical Services contract. When can Rosegarth patients expect to be able to have telephone calls answered in a reasonable number of minutes? Why, but particularly for this board, why is Calderdale so bad at recruiting and retaining general practitioners? And I'm aware that this is long-standing. I've been aware of problems in the Upper Valley for many, many, many years that have remained unaddressed. Does this board and Calderdale Cares have a strategy to address this? And if so, where is that strategy described? And is there an agreed approach to supervision and support of physician associates in Calderdale, given that they will form such a major part of the clinician input to primary care going forward? Thank you very much for hearing me out.
Thank you very much, Colin. There's an awful lot in that question, and as I think you'd appreciate, it's probably more appropriate for colleagues to have time to reflect and provide a fairly detailed written response rather than a lengthy discussion around it this morning. And certainly some of those issues, I know have been looked at over a number of months, not directly by Health and Wellbeing Board, but by the I won't get the title right, but the Primary Care Commissioning Group, which John Malaloo, who is on this call for another purpose actually, and has a new role going forward, chairs. So we may want to get some input from them as well. Obviously, the CIDL practice, which is part of the Rosegarth group, falls within my ward, so I'm well aware of the specific issues that you've highlighted with that practice. So I think we will deal with that by a written response rather than asking for too much comment this morning. I think the other thing perhaps that's relevant in terms of the wider issues about primary care, and I know you'll be aware of this, but other colleagues will want to pick up that there's recently been published the Claire Fuller deep dive into primary care. I don't know why we have to keep coming up with different titles for reports, but anyway, which is a really important piece of work about the pressures facing primary care nationally and the way that primary care needs to change. And I think that's probably something, certainly I know that the ICS will be considering, but we might want to look at that in a future meeting of this Wellbeing Board as well in the context of primary care things. So thank you for for raising those things. We'll make sure you get a written response. But I think probably also the sort of role of primary care going forward is something that we'll want to look at on our work plan at an appropriate time. Thank you. So, and it does overlap. I'll take us on then to item 6, which is reviewing the Health and Wellbeing Board terms of reference and membership. And I just referred to John and welcome him. I think it's probably specifically this item that you've come along to take an interest in, John, and I'll pick up John's new role as we go through this paper. I was asked if I would introduce this paper. So partly this is technical in that we do need to update the terms of reference and membership of the Health and Wellbeing Board, because the existing membership refers to membership from the CCG, and of course the CCG won't exist after the 30th of June. So a revised proposal for membership which picks up that and ensures continuing GP and provider representation through the proposed provider group is set out in one of the appendices to this report. But obviously, to put this into context, and we've touched on this already, from the 1st of July, the Integrated Care Board will come into being at a West Yorkshire level, and that picks up the commissioning functions of CCGs. We've been very clear that we want to see a strong and continuing role for health and wellbeing boards in the new structure. And just as at West Yorkshire level, effectively, we have the Integrated Care Board, which takes over commissioning responsibilities. And some of you will be aware that Cathy Elliott has been appointed as the independent chair of that board. Rob Webster is the chief exec designate. But alongside that, we have the West Yorkshire Care Partnership, which is chaired by myself at the moment, but we're clear that will be chaired by local government. So we see a similar relationship at a West Yorkshire level between at a Calderdale level and place level between the health and wellbeing boards and the subcommittees of the Integrated Care Board at place level, which in Calderdale will be called the Calderdale Cares Partnership Board. And John Malaloo, who I welcomed earlier, has been appointed as the independent chair of that. And as I think people are aware, Robin Tuddenham, our chief executive, will have a joint role acting as the place lead for the Integrated Care Board. So the Health and Wellbeing Board will continue to play a crucial role with that overall strategic overview for Calderdale. So I hope the proposals in terms of the revised terms of reference are clear. I know that sorry, I've just lost my screen. Governance is never the most exciting thing unless something goes wrong. As I've said before in other meetings, governance should not be exciting, but it is really important to get it right. I've got Rachel Bevans on the call. Rachel's done a lot of work on the background of this, so if there's any difficult questions, I'll hastily pass them in her direction. But it's just an opportunity to talk a little bit more also about how the structures might work going forward. So I'll pause for a moment and see if there are any questions or comments. Not see any. Just bear with me. I'll just flick back to my report as well, because I just wanted to pick a couple of things up on the membership. So, okay, yeah, sorry, I just lost my screen for a moment, so I missed the hands. So, Stephen and then Debs.
Thank you, Chair. Yeah, so on membership, it talks about representatives, plural, of the clinical and professional forum. At the moment, from the CCG, in terms of clinical leaders, it's myself and Caroline. So just wanted to be clear about what that plural representatives means, whether it's because there's 6 bullet points or 7, or are we talking about one or more members from the clinical professional forum?
Thanks, Stephen. I'll just check whether either Rachel or Mike can answer that. I notice it does say 2 representatives from a number of the other groups, but leaves the question mute on that one. Rachel, Mike, can you help us with that? Mike?
I think it should say. I think it should say two, Chair. I mean, I think the idea was to sort of carry forward the professional and clinical representation that we had from the CCG in terms of numbers into the new setup. So I would suggest it should read 2.
Okay, well let's amend that before to say that specifically before it goes to council for formal approval. Debs? Yeah,
it was just I think I mean it's so true, Councillor Swift. Your introduction, the distinct difference, isn't there? The roles between the Health and Wellbeing Board and the development of that strategy, and the oversight and the coordination of the implementation of that strategy, and the difference, I guess, between that role and the role of the Calderdale Cares Partnership Board. And I think people on the board have probably heard me say before, but I think it's really important that we're really clear that the reason that we need both of these partnerships is because the Health and Wellbeing Partnership has that oversight of the health of the population, as the paper says, absolutely has that political accountability and political oversight as well. But in addition to that, it brings together a wider, broader range of organisations that can contribute to health outcomes, and we know, don't we, that only about 15% of the influences on people's health fall within health and care services, and the other 85% fall into those wider determinants of health. So the things we were talking about earlier with Alison Lowe, for example, and the economy, the environment, etc. And so I think, we're really clear that the Calderdale Cares Partnership bit of the system will play a critical role in coordinating the health and care service contribution to the outcomes that we've set ourselves in our strategy, and the Health and Wellbeing Board will look at the whole 100% of those influences over health. And apologies for restating that, but I think it's really helpful to be clear about the differences between those partnerships, Councillor Swift.
Oh, thanks, Debs. That's appreciated. John, it's perhaps unfair of me to put you on the spot, but do you just want to introduce yourself and say a little bit about your role?
Certainly. Thank you, Chair. And hello, everybody. I think most people know me from my
my past with the CCG. So I've been Deputy Chair of the CCG. I chair the Commissioning of Primary Medical Services Committee, which Tim was referring to earlier in relation to your questions, Colin. And I'm delighted to have been appointed the independent chair of the Partnership Board. It's in a development state at the moment, as you can imagine, as we are working through cementing our governance for the 1st of July. And we are a similarly representative membership as you are indeed of this board. So there are people I'm seeing here who I will also see in a couple of weeks' time. I think the opportunity is very much as Debs articulates, which is it's about that delivery and implementation of the health elements of the strategy, and it's about doing that in partnership for what's right across the place. And therefore, I think what we have is the opportunity to make the best of how that partnership can work to look after the people that we serve here in this area. And therefore, I think that's what's important for Calderdale, and that's how we intend to work with you. And I'm delighted, Chair, to be allowed to come and observe today. And I'm sure this won't be the first conversation that I'll be part of over the coming months and years.
No, thank you, John. And I mean, that is a point that occurred to me, is whether you should be a regular observer if you choose to, in some form of this, and perhaps that's a conversation we can pick up outside this meeting. I mean, we certainly have that kind of dual sort of cross membership at the West Yorkshire level, and we might want to talk about how that works going forward as well.
I think so. Thank you.
Thank you. Okay, are there any other questions or comments on this? As I say, formally this needs to be referred forward to council for approval. Also, perhaps to note under this item, in terms of kind of non-voting councillor membership, which we've had on this panel, we do now have a new cabinet member for public health, Councillor Courtney, and I think it would be helpful for her to be able to attend and speak at this meeting if members are happy with that. Okay, so that will all be captured in a report that goes forward. Thank you. And thank you, Caroline, for that offer in terms of primary care. We'll make sure that's in the chat, make sure that that's captured. That's really appreciated. So if I could take us on then to item 7, the pharmaceutical needs assessment, and Debs, I think you're going to introduce this item.
Yeah, thank you, Councillor Swift. So one of our responsibilities as a health and wellbeing board is to ensure that a pharmaceutical needs assessment is undertaken every 3 years. And what we're doing today is we're bringing the pharmaceutical needs assessment that's been undertaken to this board for approval for a 60-day consultation with key stakeholders. So that's the reason that we're bringing this report today. We were actually due a pharmaceutical needs assessment last year, but with the pandemic and the people that work on these needs assessments being busy doing other types of surveillance work across West Yorkshire, this has been delayed for a year. So these reports, these needs assessments, need to be done every 3 years. So this document that we've got in front of us today is the pharmaceutical needs assessment for 2022 to 2025. And what it does is it looks at the current provision of pharmaceutical services across Calderdale, so the different services that we've got in the borough in quite some detail. And then it also looks at the population of the borough, the population now, and the size of the population we predict there to be in the future, and looks at also the health needs of that population. And then what the report does is looks at the gaps between the pharmaceutical services that we have and what we what the current need is and what we predict the need to be in the future. So there's a lot of analysis in the report. There's also in one of the appendices the results of a survey of people that we promoted through our website, asking members of the public for their views about pharmaceutical services as well. And again, I think that's summarised in Appendix 2 of the report. We had 134 people responded to that survey, and the conclusion of the pharmaceutical needs assessment is that we haven't identified any current or future needs that can't be met by the current provision of pharmaceutical services in Calderdale, and nor have we identified any potential pharmaceutical services that aren't currently being provided that are needed by the population. So I'm going to stop there, Councillor Swift. There's a lot of detail in the report, and we're asking for approval for a 60-day consultation with a wide range of stakeholders that will then inform a final version of the pharmaceutical needs assessment.
Thanks very much, Deb. So there is an opportunity for people to feed into that consultation, but are there any questions or comments at this point on the draft report? It's one of those interesting points that sometimes I think there's a danger with these things. You don't, as a layperson, you don't see there's an issue until too late. So it's just worth exploring that. Ian.
Thank you, Councillor Swift. And I think a little bit, this is one of those documents that people can be either really engaged in and feels really important, or people think, oh, as long as the ratio of population to access feels right, it's okay. But it's a very important thing, I think, in terms of both understanding access to pharmacy support, but also thinking about some of the questions I think posed by Councillor Hutchinson in terms of future service models and how things might need to adapt. And I think, Debs has quite right identified that there might not necessarily need to be new framed services, but actually how might those service contracts need to adapt in the future to meet some of the real workforce pressures that have been described across primary community care, that actually might mean that people are able to more proactively take some actions about their own well-being. So I think whilst it might feel quite a bureaucratic process, potentially this is a way of influencing and shaping health in communities quite significantly. So I kind of welcome the opportunity, because obviously with the pandemic we've not been able to refresh this earlier, but I think it's a really important document which other people might think, oh, it's a bit of a cold fish, but I think it's really potentially changing the shape of way in which people could access good information about preventative services.
Thanks, Ian. Yes, that's really, really useful, and see Anna picking that up. I suppose linked to that, I know this isn't directly about pharmaceutical needs as such, but I am aware that there was issues, certainly going back a few months, I think some of them continuing, with sort of supplies of particular and quite important drugs. And whilst I appreciate that's not directly about the pharmacist, I wonder if there is actually also an issue about variable access between kind of, say, community locally run community pharmacies, which we all incredibly value and want to support, and some of the bigger chains. I'll leave that question with you, Debs, and I'll bring Ashley in as well and then bring you back. Ashley.
Thanks, Chair. I'm just a total neophyte when it comes to pharmacies and things. Just a general question, two general questions. One, is there possibly a danger of being too complacent about the current situation? I have no knowledge to substantiate that one way or the other. The other question relates to the consultation process, obviously a necessary element. is it possible to know who is likely to be involved in that and who can actually comment on the whole thing? Thank you.
Thanks. Okay, Debs, a couple of things for you there.
Sorry, I'm struggling to find my mute button there, Councillor Swift. Apologies. Yeah, that really helpful comments. I mean, one of the purposes of the pharmaceutical needs assessment is to as pharmacies are a commercial, operate in a sort of a commercial environment. One of the purposes of the needs assessment is to identify whether there is a need for additional pharmacies. So there's almost like an entry into the market, permitted or not, if you like, or encouraged or not by a pharmaceutical needs assessment, and that is one of the functions. So you're absolutely right. I mean, the model of pharmacy, there's an element of this that's about how many pharmacies we have and are they providing the right services, but there is also an element, absolutely, that this can influence, but doesn't need to wait for a pharmaceutical needs assessment, around the model of service delivery and how we work across primary and community services. So I think that's a really helpful question, a really helpful comment there from Ian. In terms of the ordering of drugs and how drugs that there are shortages of get into the right pharmacies, that the pharmacies do order. There is a sort of an ordering process, but where there are shortages, there is a process by which the commissioners of these services, which is NHS England, try and ensure that there's a sort of a fair allocation across places. How sophisticated that is, I don't know the answer to, Councillor Swift. I'll look into that and try and find out how sophisticated that process is. In terms of the Councillor Evans's question about the consultation, there is a section of the report that sort of summarises. There's two elements of the consultation. There's the people we statutorily have to invite to comment, and I'm just looking for which page because that is listed on one of the pages, which I'm just looking for now. But what we will do is we make it widely available. So the local pharmacies, local GP practices, our neighbouring areas as well. We have to make sure that we send the consultation to them. Health Watch, our local health organisations. We need to make sure that we make this available too. But what we've done in section 2.6 of the report, we've talked a bit about the consultation. So it'll be publicised through our website and our social media account, and we'll really try and encourage people to respond to the consultation. And we will also work through Health Watch and also promote it to our voluntary sector partners as well. So we will be looking for a wide consultation on the needs assessment, but there are some people we'll specifically write to because we have to that are key partners, Councillor Evans.
Thank you. I haven't specifically checked it, but Julie tells me that page 65 of the document deals with the, I'm not sure whether that's of the report itself or the covering report, has a bit more detail on the consultation. So there's something there for people to pick up on. I'm assuming, Ashley, that's a legacy hand and not that you want to come back.
It is indeed, but I didn't hear a response to the complacency comment.
Yeah, it is a really good point, Councillor Evans. I think, as I said, because part of the function of this document is to decide if we need additional pharmacies into our market in Calderdale. Some of the recommendations are worded in such a way as that we have enough pharmacy to meet the needs. It isn't about being complacent, and I think Ian raised some really important points about the really critical role that pharmacy makes and increasingly is made actually, including during the pandemic. And while our primary care services are under so much pressure, increasingly that's where I go most of the time when I'm seeking health support for myself or my family. So I think there's something about the way that we need to word the recommendations that are about this entry of new, potentially whether or not there needs to be entry of new pharmacies into our local economy, which we have to word in that way. But yeah, absolutely, we're not being complacent, and those developments about how pharmacy develops in the 3 years that we've got our pharmaceutical needs assessment, and what those delivery models are really, really important. And they are conversations I know that we have a lot about the role that pharmacies can play in our pathways, really, in terms of the delivery of clinical care.
Thanks, Debs. I suppose on a similar point, and again, it's kind of pushing pharmacy generally rather than necessarily specifically the needs assessment. I guess there's an overlap here between the work on sort of integrated data systems and data sharing systems, and I suppose just welcome some reflection, not necessarily now on that. Does it obviously if people go to the pharmacy for a repeat prescription and it's not there, that then creates another call or visit to overworked GP receptionists, for example. If updates on medication from consultants don't get properly picked up and processed again, it puts more noise and chatter into the system. So as I said, I'm not expecting an answer to that now, but if people just want to, I would just be interested privately in a sort of a response on how well we think those systems work, and if there's any investment we need to press for a support there. Stephen?
Thank you, Chair. I'm just looking at page 9 of 85, essential services, just trying to join some of these dots up. One essential service that pharmacies provide is called repeat dispensing. I don't know if everybody understands what repeat dispensing is, but if you're on a medication and you need to request it from the surgery every 28 or 56 days, get the prescription, take it to the pharmacy, or it gets sent there, that can take 6 or even 12, often telephone calls or e-consultations with the surgery to get your prescription. The repeat dispensing prescription is a batch, usually of 1 year, of prescriptions that's sent to the pharmacy electronically, lodges with the pharmacy actually on the national spine, and each month drops down, or each 2 months drops down into the pharmacy for them to dispense the medication. Some of you may be nodding, some of you may be in receipt of repeat dispensing medications. It saves time for the practice, saves time for the patient contacting the surgery, be it on the phone or electronically, and it helps community pharmacy manage their workload, because they can be getting those things ready for the day that collection's needed, and then the patient just presents themselves to the pharmacy and collects them on the day. If medications aren't needed, then they can take them out and they don't get thrown in the bin and wasted or incinerated, but they can, because they haven't been touched, they can go back onto the shelf. So repeat dispensing saves money, saves time, saves energy, saves resources. And if we can promote that as a system to be utilised far greater in Calderdale, our own practice is one of the highest users of repeat dispensing nationally. So we've got quite a good deal of learning about it for the last 15 years. If we could promote that, it would help all parts of the primary care system.
Thanks, Stephen. I think that kind of information areas of how we as a wider system can help with those kind of information and promotion of things that make the system works better is one of the ways we can work cooperatively to reduce some of those pressures on primary care, as you say. Have to say the practice I'm with, the Boulevard, the repeat prescription service works really, really well. Debs.
It was just it's a really interesting conversation, isn't it? And useful, and that insight there from Dr. Cleesby is really helpful. And I wonder, if there is some value, perhaps in one of our informal sessions, to have a bit of a discussion, perhaps with Pharmacy West Yorkshire, just about the role of pharmacy in Calderdale, how it can help contribute to our priority outcomes in our wellbeing strategy. So just a suggestion really, so we can get into, I'm no expert on pharmacy. I guess my role in this is the needs assessment, and my team's role is the needs assessment, but potentially that might be something that we could explore if members of the board think that'd be useful.
Thanks, Debs. I think that might be really helpful. We'll take that back to the planning agenda setting group and look at plans for future informal sessions and how we might build that in. Okay, with those questions or comments, can I take it that we're happy to agree that draft for consultation? Okay, thank you very much, everybody. So item 8, system pressures. This is a verbal report, which I'm going to ask Ian to kick off and then see if any partners have anything to add. So Ian, over to you first.
Thank you, Councillor Swift, and board members will realise that through the pandemic, we added this verbal report just to kind of understand some of the pressures that we were experiencing across the piece, but largely driven by COVID. I always feel a little bit nervous when I say that actually we are doing relatively well with COVID outbreaks at the moment, and certainly in health and social care, it has been a considerable number of weeks where we've had confirmed outbreaks. We have had single cases, but I think and I am aware that what we're seeing across the health and social care footprint is we are still seeing cases of COVID, but we're also starting to see emerging outbreaks of norovirus in particular. And that's not the same across West Yorkshire. So we get West Yorkshire recording, and we are seeing in other places more COVID outbreaks and more norovirus than we are currently seeing in Calderdale. And I think some of the embedded learning that we learned through the impact in terms of infection prevention control is still holding strong, even though the workforce is generally tired. I think we are still experiencing the biggest impact the whole system is facing is around workforce, both in terms of the emotional and physical resilience of the existing workforce, people being attracted into health and care is still challenging. And I'm sure partners will talk more broadly about some of their own challenges, but certainly in health and social care, we're still finding it challenging to attract people towards care in particular as an area of work. And I'm really pleased to be one of my final things that I'll do as Director of Adult Social Care is on behalf of Cabinet be writing a report that will look at how we can improve the terms and conditions of people. And we've often talked about low skill economies. Social care is a high skill but low remuneration. So we'll be bringing forward hopefully a proposal to Cabinet to see how we can invest in that element to really create some resilience across health and social care. Because if we haven't got social care either as a preventative model or to support people discharging hospital, the system flow becomes really challenging, and certainly currently the system flow isn't where we want it to be. So I think that's my kind of perspective. I just wonder whether other parts of the system, maybe the Mental Health Trust and primary care and mental health and the acute trust might want to come in as well. Stun people into silence.
Okay. Thanks, Ian. Anna, do you want to come in?
I think, yes, just I'd reiterate what Ian has said. It feels that there is a relatively more stable position in terms of demands in the system currently. Relevant to COVID, we've currently got approximately 17 inpatients being treated for COVID, a very low number. And our priority is really about addressing the backlogs of our waiting lists and recovery, which we're making good progress on during the first 2 months of this year on our overall trajectories. And one of the first milestones regarding that is the elimination of anyone waiting over 2 years, which I know is an excessively long time to wait. We're very pleased that we're on track to achieve that and making further progress throughout the year. So I'll just reiterate what Ian says. Workforce continues to be challenging for us, but as I say, it does feel more stable in terms of that, definitely around the demand around COVID.
Thanks, Anna. Any others? Stephen or Caroline or Neil, is there anything you want to add from a primary care perspective? No, okay. Stephen, yeah, sorry, I'd lost you for a moment.
Not just from a primary care perspective, I don't think Anna's comments do justice to the fantastic work that's happened over these last 6 or 8 weeks at the Acute Trust with the help of managers from the CCG, looking down to actually individual and patient level, seeing how long they've been waiting, what are the reasons, if they've cancelled appointments or procedures, helping them to get to the hospital and rebook and all kinds of things. And the trajectory is absolutely incredible. Whilst we've had this challenge for the last couple of years, we've seen virtually a downward trajectory towards target on virtually every specialty. So still a couple of pockets of challenge, but some brilliant work. If we could share the graphs, it would be amazing. So I think CHFT need to be congratulated on that. And just around primary care, I didn't open up the topic because, of course, we need to think more carefully about the answers to Councillor Colin Hutchinson's questions earlier on. But in terms of the overall demand, it's unprecedented. I think from before the pandemic to now, we're looking at an extra 50% demand with the same workforce and the challenges of cost of living, etc. So in primary care, it's never felt, I've been in general practice in Calderdale since the 1st of August 1999. It's never ever felt as difficult. And whilst many patients are very understanding, very kind, very appreciative of what help and support they receive, obviously some aren't getting the care that they need and deserve. And that frontline access into telephones and computer systems, just getting an initial contact is very, very challenging. The demand is unprecedented, and we don't have an extra 50% of reception staff to answer the phones and answer the computer systems. So it is extremely difficult at the moment. And I think morale's probably at an all-time low. Yeah.
Thanks, Stephen. I mean, I mentioned the fuller deep dive earlier, and the discussions I've been in on that. You know, that this is a national, that's very much a national position, and the worrying issue is the number of people who are leaving from primary care, not just or not necessarily predominantly GPs, but as you said, ancillary staff, reception, and so on. Caroline.
So just to say, really, that I think this is such a complicated, nuanced issue to discuss. There's so many different aspects to it, and the stuff that's going on nationally and locally in Calderdale. I really would recommend and welcome the idea of actually having a full session to discuss some of the complexities of how we actually work through this, to understand where the national drive is, but also where we want to be going locally and how we marry the two together. So I think, yeah, agree with Stephen, morale is at an all-time low, but there is amongst the sort of national leadership and regional leadership some cautious optimism that directions of strategic change might be going to move in the right direction. I think we'll know more over the next, we will know more over the next couple of months. The Secretary of State's made that very clear. Secretary of Health made that very clear yesterday. So I think probably if we did something in a couple of months, that would be a good time to be taking it forwards. But if anybody wants any conversations about it, you know, outside of this meeting, I do generally have my ear to the ground quite closely if anybody wants any more information.
Thanks very much, Caroline. So can I just come back to that CHFT point? Because I think I'd not fully fully picked up just sort of what's going on there. I mean, I don't know whether there's a quick report for information that could be shared. I don't want you to write anything extra, and I don't know if there's anything else already available that you could share that just gives people a flavour of what it is you're doing and how it's impacting.
I think we'd be very pleased to do that. I mean, clearly we've still got a lot to do over the remaining months of the year to fully meet our trajectories, but there is some really encouraging progress, and certainly across many of our medical specialties, we're well in excess of planned trajectory for this point in the year of volume of patients that we've been able to bring off the waiting list. So yes, it will provide something concise, and just to reflect back again to Stephen, the partnership between CCG colleagues working alongside the trust around some of that work has been very positive and helpful. So I'll do that.
Thanks. I'd say, yeah, somebody who both directly for family members has been navigating the NHS recently rather more than I'd wished to. It's been quite interesting to see how quickly some appointments have come through. Also, I was quite interested to see in terms of a positive of using the estate differently. I was summoned for one of these various screening programs that remind you that you're getting older yesterday, and that scan took place in the GP practice rather than in the hospital, which I found pleasantly surprising, and was very, very, very quick and efficiently done as well. Debs.
Yeah, apologies for this, but I think it'd be remiss of me as well not to just say a little bit about COVID and where we are. We are actually following the second Omicron wave. We sort of settled right across the country actually at about 2% of people, about 1 in 50 people with COVID, which is still a lot and higher than any other period prior to Omicron. We are seeing an uptick. The data isn't as reliable, but the survey that the Office of National Statistics do of where they test a random sample of people, that's showing an uptick in Calderdale particularly actually. So now it's around 1 in 25 people at the moment we estimate have got COVID. We according to that data, and it isn't as reliable as previous phases in the pandemic, we are perhaps a little bit higher than other parts of the country, and it is. And the second thing really to say about the variant that's the sub-variant of Omicron that's circulating at the moment just seems to be causing illness and disease in lungs more than the previous versions of Omicron. So people will be aware of more like a head cold, you may remember, and higher up the lungs. It's seeming to cause more lower down in the lungs. And again, that is a concern for us as well. So I guess what I'm saying is all the issues that have just been raised by colleagues, it may not get better quickly if that situation continues to in the trajectory it is at the moment. Sorry to be the bearer of bad news.
Thanks, Deb. No, but I mean this is obviously this item is so people are aware of the pressures in the system, and I think it's right we flag that up too. Okay, thank you. Thank you very much, everyone, for that. I don't see any more questions or comments, so I will move us on, if that's okay. So item 9 is the forward plan, and can I ask Mike Lodge to introduce this? Mike.
I don't think I've got anything to add to it, Chair. I think that we'll pick up on the discussions we've had, particularly about the informal discussions around pharmacy and primary care, and bring that back to the agenda setting meeting.
Thanks. Yeah. So just to remind members who are new to this committee, we have informal sessions that take place between each meeting, which provide an opportunity to explore topics in more depth. Sometimes then lead to formal reports coming back to this, back to the public meeting. Sometimes they're simply kind of for background and to briefing and to explore topics. So you'll see those as we move forward. But I would say that in terms of becoming part of the work and understanding it, they're really quite as important as the formal meetings. So if there's nothing else, then I will thank everybody for their time and contributions, and bring the meeting